We're going to jump straight into the treatment of joint contractures, and we're going to focus a little bit more on knee and ankle. I've been teasing you guys with that the whole day. There you go. So, in a nutshell, joint contractures can occur from a lot of different conditions, from prolonged immobilization, nerve injury, ICU stays. It can be caused by burns. It can be caused by trauma. They can be iatrogenic. So there's a wide array of reasons why people would be stiff. Here's a few in front of you. And disability caused by stiff, painful, and weak extremities is significantly greater than disability caused by a short and deformed skeleton, right? So as a rule of thumb, we do not want, as surgeons, to take short and deformed and make it stiff, painful, and weak instead. And our first step is to first try to differentiate, well, what is contracture and what is deformity? Earlier on, we learned how we do that by analyzing the SMA and the SJLA for the knee. And really, it starts by mapping the ABC. This is a young gentleman who came to me after a cosmetic lengthening done elsewhere. And after multiple attempts at correcting it, it was just being worse and worse and worse by the initial surgeon. And it's caused by a combination of poor entry point, poor blocking screws, lengthening, and so forth. So how much of this is bone? How much of this is soft tissue? Well, first you have to know this by heart, right? So my recommendation at some point throughout the day is, I hope you took a picture of this. If not, find it online and carry it around in your phone. And initially, this guy was purely a bony deformity. So this was not a contracture. It looked like a contracture, but it was really a bone deformity. And once the bone was corrected, he got his normal anatomy back. This, on the other end, was a young 40-year-old woman who suffered a motorcycle accident. She's a military lady. She suffered bone loss of the proximal tibia with a bone reconstruction done at Walter Reed in the United States, which is the main military hospital. So by analyzing the angles, we realized that proximal, she has a contracture because her PPTA is completely normal. However, distally, she has a deformity. So she has a combination of both soft tissue proximally, but bone deformity distally. And we can only figure that out by analyzing the angles, figuring out the SMAA, and establishing how much of this comes from the bone, how much of this comes from the tibia, like I taught you earlier. This, on the other end, was a young woman that had a retrograde lengthening done once again elsewhere. And she was kept I think she kept herself in a knee brace for about 3 weeks as she was lengthening.
All the way, push it down.
This is how she
now
presented.
Lift up.
Presented with about 15 degrees of range of motion.
Keep going, good job. Now bend again.
Patellar tendon, because of synostosis between
and
the
lift up.
And the femur. And you can see on
All
the
the way,
CT scan
all the way.
the synostosis.
Good job. Now bend
Perfect
again.
Bone bridge. The perfect bone bridge between the patella and the entry point of the femur.
All the way, push it down. Now lift up.
So she's stuck now with a contracture with a bony component to it. This is after
Full straight.
a thorough treatment of her contracture, where she regained about 80 degrees of range of motion, which is close to her baseline.
Full bend.
So how do we go from a contracted leg, now that we've established that the problem is a soft tissue issue, to a limber joint? Well, first we have to address the treatment ladder. We go from least aggressive treatment that is realistic to most aggressive treatment. And my treatment ladder starts with conservative treatment, continues with an acute correction, and in cases where it's not possible, we consider gradual corrections. Conservative treatment has to happen through with the help of our physical therapist friends and greatest allies. And really, it's done through stretching. There's no other way. And flexibility is a function of duration of stretch, frequency of stretch, and intensity of stretch. Now, but when I mean stretch, I don't mean actual just stretching exercises. It's a multimodal strategy that goes from dynamic bracing, that goes through manual therapy, pharmacologic therapy as well to help the physical therapy happen, and other modalities such as TENS, manual stimulation, ASTIM, eSTIM, etc. This is a very interesting graph that shows that there's two ways to obtain a good stretch. You can either force a lot, but for a short amount of time, and that's what happens with a physical therapist, right? The physical therapist sees your patients for an hour at a time, maybe 3 times a week, but as you can see, they apply a lot of force, up to close to 50 Newton meters per minute per week. However, totally in a week, they'll have about 446 Newton meter minute per week. However, when using dynamic splints, then patients end up with a much lesser force for a prolonged amount of time. And throughout the whole week, throughout an extended amount of time, they end up having a lot more pressure, a lot more force exerted on their joint, and that's why dynamic bracing works so well. We use a lot of different types of dynamic bracing. We craft in our institution custom ankle and custom knee devices, which are basically fiberglass type braces with hinges that have elastic bands attached to them, and the elastic bands are from different amount of tensions and can be applied for up to 8 hours per day. They can be done for flexion, they can be done for extension. Now, it's really important to remember that when we do it at the ankle, the subtalar joint has to be neutral, the midfoot has to be locked. And if that's not the case, all that force, instead of being dissipated through the ankle, is going to be dissipated through the midfoot and hindfoot, and you will not obtain the stretch that you want. So the subtalar joint must be neutral or slightly inverted, and the Chopard joint has to be locked. The second thing is the brace needs to cross the knee, as a knee extended will have a lot more impact on the gastrocnemius than a knee that is flexed. So if the brace is not encompassing the knee, then you lose all your strength because the gastrocnemius is not put under tension. And finally, eccentric loading of the tendon to obtain that lever arm that is necessary to obtain the stretch. Now, when is it that this type of treatment, the conservative method, will not work well? Well, usually if there's that doorstop or that hard end range in the joint, these conservative methods will not work well, and that's when we start thinking about surgical corrections. Acute corrections are a good way to proceed because it's a one and done. There's no need for a cumbersome external fixation device, and they can be achieved through capsular releases, tendon lengthenings, or recessions of aponeurosis, or lysis of adhesions with your arthroscope, or even open intra-arterial debridements and arthrotomies. Now, the downsides of those methods, especially when we start talking about tendon lengthenings, we decrease the muscle to tendon length ratio, and that is what creates weakness. Also, for severe contractures, neurovascular injuries can happen, right? So you might think you're doing the right thing by correcting an acutely a 45-degree knee flexion contracture, but when the patient wakes up, they have a drop foot. Nobody won. Or at the end of correction, you lose the pulses, and all of a sudden you have to give up some correction and revert back to a gradual correction. So keep that in mind, that acute corrections can be a double-edged sword. This graph illustrates how much lengthening of a tendon, and sometimes just up to 1 to 2 centimeters for most of these muscles, can reduce muscle strength permanently by 50%. And all these muscles, the soleus, the tibialis posterior, the gastrocnemius, the tibialis anterior, all around the foot, and the rectus femoris and cerebromembranosus around the thigh, don't require that much lengthening to weaken permanently. And these patients might lose push-off, difficulty running, inability to jump, going up and down the stairs, and I think it's a catastrophe. And they become very unhappy about that. And that's when gradual corrections come into play. So gradual corrections in our practice will be reserved for patients who have severe deformities that cannot be corrected acutely, or that would require lengthening of the tendons more than these 1 to 2 centimeters and to prevent weakness. And we use them usually when all else fails in the absence of skeletal deformity. Why? Because if there's a skeletal deformity, it has to be corrected as well. We're talking about deformity and not contracture in those chapters. So the big benefit is that we maintain that muscle to tendon ratio, and thus we maintain strength. And the gradual corrections are extremely powerful. They can power through some of the most rigid deformities if the external fixators are well positioned. And there's neurovascular adaptations that prevent blood flow problems and palsies. So it's a 4-step method. It's a method in which we obtain the correction, we maintain it, we overcorrect it, we maintain it, and then we brace so that once the actual surgical process is done, we do not lose the ground that we've gained. To obtain the correction, first you need to identify very properly what the center of rotation of the joint is. We have seen what the center of rotation, at least from 0 to 90 degrees, is around the knee. And in the subtalar joint, it's the junction between a right angle line that passes through the weight-bearing aspect of the foot, 90 degrees through the lateral process of the talus, and a straight line through the diaphysis of the tibia. So it's usually located at the subtalar joint. Once you've located the joint, the hinge of the joint, the first step is to apply distraction to that joint, because powering through a joint without distraction and trying to obtain extension or flexion will crush the articular surface. By distracting the joint, you loosen the tissues, you spare the cartilage, and finally, as a rule of thumb, about 1 degree a day is neurovascular friendly for the joints. So this is the example of a 28-year-old male from China who had intravascular chemotherapy for, I believe it was some form of angioma of the calf. And he presented to my office with a complaint of leg length discrepancy, which we actually found out it was not. It was just a rigid equinus contracture of the ankle. So we applied a hexapod external fixator, very simple, 2 pins in the tibia and some wires. And over the course of 3 months, we corrected his 55-degree equinus contracture. And we went, you'll see right now, in about 15 degrees of dorsiflexion, and we maintained it for 6 full weeks. This is the ankle X-ray at the end of 6 weeks, and you can see that he maintained some strength, whereas he did not have any dorsiflexion before due to the rigidity. All of a sudden, by restoring the tension on the Blix curve, he was able to start moving. And his only wish was to start playing basketball, and he was actually able to start running after that. Had we done an acute correction with tarsal tunnel release and the whole kit and caboodle, this patient would most likely not have had the same push-off strength at the end. This is a 55-year-old male who has a 7-year history of below-knee amputation. And he was not compliant with physical therapy initially. That was done somewhere else. And due to this 30 degrees of flexion contracture, was never able to be fitted with a prosthesis. Now, soft tissues have memory. And overcorrection is so important because the natural tendency for the joint is to come back into its original position. So I tend to recommend up to 15 degrees of overcorrection. Now, this is an example of how this rule was not respected. It was broken. So I applied a regular Ilizarov external fixator, applied some distraction, corrected him to neutral, and maintained for 6 weeks. Once we maintained it, he came back a few weeks later. He did his physical therapy, but as you can see, we lost about 10 to 15 degrees of correction. So don't be me. Overcorrect by about 15 degrees every time to every joint. And this is the same gentleman a few weeks later. So despite that, was able to be fitted with a prosthesis. It was a very emotional moment because it had been 8 years since he had walked. So it's life-changing for this gentleman. This is a case I did when I was a fellow with Dr. Herzenberg, a gentleman who had seizures but yet kept on driving and got into multiple car accidents, and developed equinovarus contractures of his ankles, flexion contracture of his knees, and was treated for the ankle with a miter frame. So this time we didn't make the same mistake, right? We obtained the correction gradually. We we overcorrected 15 degrees. We maintained the position for 6 weeks. And then at the end of the correction, we put him in a cast to make sure that he would keep the correction and maintain the position for many months after that with bracing. So this is him before correction. This is him after correction. I hope he's not driving anymore. And finally, once the correction is achieved, you want to make sure that at least for 6 months, up to a year, you brace these patients at night to keep that correction and prevent you from losing ground. And you want to continue physical therapy and daily stretching. So in summary, treating joint contractures starts by identifying the problem properly. And I think you've started learning that method today. So we increase the treatment ladder by going from conservative treatment, physical therapy, bracing. However, when all else fails or it's a hard end stop, acute corrections and gradual corrections for the appropriate patient is the right way to go. And gradual correction really is the ultimate end range, stretch over time. So it's the ultimate bracing. It's the most powerful one. And it's a very good alternative to an acute correction. Don't forget, obtain, overcorrect, maintain, and brace. This is that patient riding her motorcycle again a few years later. And I'm showing this with her consent. Any question? Yes. So there's two parts to your question. So the first question is, how do we know if for a long-standing chronic contracture, if the cartilage, if the joint is still viable? It's a discussion that I have with every patient. And I looked through the literature, and CT scans, MRIs are not so great to come up with that answer. In the knee, I will do an arthroscopy in most of these patients to have a look at them. And when you put an arthroscope in there, it looks like a cobweb of hell. So one of the first discussions I'll have with these patients is, your joint hasn't moved for a year, 2 years. Right now it's painless. It might become painful when I give you some range of motion, so brace yourself, right? But as soon as you regain range of motion and you can preserve that range of motion, then you have a good prosthetic alternative versus trying to do a joint replacement in a completely stiff, immobile knee. The greatest predictor of range of motion post total knee replacement is the range of motion pre-knee replacement, right? So at least you set the table. That's number one. So all the patients, I let them know, I don't know how viable your knee will be, your ankle will be. I can get you straight, but I can get you painful as well. However, from there, we'll discuss. The second question is, does shortening have a role? I think shortening has a role in the acute to subacute period, but once the contracture has set into the capsule, once arthrofibrosis has set in as well, then there's no amount of shortening that will touch it, right? Shortening will work if that contracture is due to muscle strength. All right, I'm being told we have to go.